be anyone now in New Zealand that in general practice that hasn't realised that we can change and it's actually quite doable. So coming out the other side of COVID, I think there'll be many of us who go, actually that wasn't as bad as I thought it would. But Sam, I think the green eggs and ham aren't going to be as nasty tasting as we thought. And I hope that what we have embedded in the last month with change actually stays, because it's been good, I think. So we often talk too about triple aim, that's 1, 2 and 3, and I often talk about patient experience. And I have mentioned already, I think that one of the great things that's come out of the healthcare homes work in my practice is it's been better for my care, the well-being of my care team, guys I work with. Our practice was absolutely swamped with urgent and unplanned care. It was a train wreck, literally, and we weren't coping. And although we're still really busy, in the last 3 years, it's organised busy, it's manageable busy, it's actually an okay busy. And I think the atmosphere of my practice, the environment has improved no end. We've even lost 2 full-time equivalents over the last little while, and we've just coped because we've got things working much more efficiently and we're working as a team. And it seems to be working around the country. We've now got 1.3 million New Zealanders across New Zealand are inside a healthcare homes practice. And that number would grow really rapidly probably in the next year, because many of the organisations inside the collaborative are only just starting. So many are very early on in terms of enrolling practices. So this is not again driven by the ministry or by your DHBs or by your PHOs. It's actually driven by generally clinical leaders and people that think this looks like a good idea. And there's a whole swag of them, as you can see there. And they're all coming from different angles. So they've got different funding, no funding, different drivers, but they're all working together because we're all smarter together than we are on our own. And we can't make all this collateral in terms of change readiness without actually working together. Many of us have been on it longer than the others, go to meetings and learn things from some of the newcomers who've come on with brand new ideas, and we just walk away every time going, that's a great idea, I'll have a crack at that. From a patient's point of view, this model of care is really about, I guess, with urgent and unplanned things, keeping people, giving them access when they're feeling unwell. It's about preventative care to make people with long-term conditions stay well. It's about routine care for people who want to stay healthy, and also business efficiency. So when people come to our practices, the places are running well and they feel like they're having a nice experience inside our rooms. So that's the patient view. There's a beautiful little video clip of that done by the collaborative, and I won't show you it, but if you went onto YouTube and just looked up New Zealand healthcare homes model. And so, from a patient point of view, our ability to do with unplanned or urgent care, the ability to get your appointment on the same day if it's necessary, is so much easier inside a healthcare homes practice. We're really trying to work on getting care plans for all those that need it. We're within our practices trying to have a better coordinated team of people we work with. We're trying to triage people so they actually see the right person for the right length of time at the right time. We're offering alternatives to face-to-face consultations. I think that much of the country before healthcare homes was driven by just 15-minute face-to-face appointments, trying to do things by triage calls, by telephone consults, by management health messaging or video consultations. Certainly the last month has shown that's doable. It's doable not just inside healthcare homes practices, but everywhere. We've been driven down that track very rapidly. The improved telephone access is not so much about the triage, but actually more about making sure your phone systems work. And some of the stuff we found out when we started in our own practices, there was a whole lot of drop calls, people waiting a long time, and we've done a lot to make that experience better for patients, which is actually better for business. All of our health games practices are hell-bent on raising portal numbers. Portals are fantastic for patients. They're also really good for practitioners within the practice. It's a different way of doing your work, but it's beneficial both ends. We're also trying to improve how we communicate information to patients. Not great fan, I didn't write that slide of the word health literacy. I think our job as providers is to make things clearer. It's about health parity. And for practices, as I said, we're better able to manage our daily workload through triaging. The train wreck has stopped in my own practice. We got the train back on the tracks. We're certainly actually more efficient then by reducing acute same-day demand. We're actually making sure that clinicians can spend their time doing things that actually more useful than seeing people that don't need to be seen. Certainly, from a patient experience point of view, if you don't need to come to the practice, you can be sorted out in a couple of minutes on a triage call. That's good all around. My own practice has definitely increased the size of our team. We've now got 3 medical care assistants. We've got a health coach, a health improvement practitioner, and we're working much more collaboratively with our pharmacists. So we're also then spring up some time to do more proactive planned care, which has been very useful. We've got coordination, I guess, within the team itself, but also we're trying to actually coordinate things outside of the practice with other providers in our network. And interestingly, and not surprisingly, some of my colleagues who are very unkeen on launching into this when we first described it are actually happier in their jobs. They're actually looking forward to the next few years of general practice, and have felt that this has been one of the things that's made a big difference to their quality of practice, which is really great. This is a slightly cheeky. I think that we've seen a lot recently about the expression virtual consultations, and I take slight objection to the use of that. We've got alternative ways of doing things. They're real ways of doing things. They're not virtual. Virtual often implies a sense that they're not quite as good. I think what we found in the last month, that some of the things we're doing, which are other access points, are just as valid, just as real, and just as good for patients as they used to be. We'd already embedded many of these things in our healthcare homes. So, triaging patients, telephone consults, video consults, messaging consults were all in amongst it anyway. The last month's showing that those can be ramped up considerably, and hopefully will carry on in places that weren't doing it, seeing this quite manageable to do it. We've certainly noticed that it reduces volume doing triage of same-day urgent care. Prior to COVID, my practice was resolving 40% of all incoming calls for the day over with short triage consults. We're doing triage all day now, the GPs, just because of the way it is, and we're now resolving, when I last looked, 72% of all incoming calls in the last month since we got lockdown have been resolved in a triage call. Seems that patients have transitioned pretty well to telephone consults. Interesting enough, the nirvana always seems to be, we talk about video consults and how we should actually be trying to do more of those, but technically they're more challenging both for patients and providers, and it would be nice to have some very slick technology. I'm using Doximity, which is absolutely awesome, but it's not as straightforward as picking up the phone. The day will come, I think, when that will be, but to a large extent we've coped very well just with telephone consultations. The other thing you may have noticed in practice that got a portal is the traffic on portal has really substantially increased in the last month with COVID. We've gone up 50% increase in the number of incoming and outgoing messages. I think the last thing there, which I put in capital letters and probably won't speak to too long, is that I think it slightly exposed the absurdity of our current funding model in general practice, that you make money through capitation and face-to-face consults. All those alternative ways of doing things are all legitimate, and yet they're not really supported or encouraged or funded in a way that really makes sense. But I haven't got time to go in that. Lamajit told me I had 15 minutes and that would take me an hour to talk to. I'll just talk very briefly again about triage, which I've mentioned, but it does seem to give our patients value their time. Don't need to come in, especially in Northern with bad roads, bad cars and long distances. A great advantage, you can be sorted out. It does give another way of doing things. It's improved my business efficiency, which again is another conversation, but the fewer people I see, the more efficient my business is. High utilisation leads to lower income practices. We've lost our train wreck demand. We're doing things more proactively and our patients enjoy it. Dare I say also, my clinicians really like doing triage. They got used to it and now would never go back. That model I showed you with from the patient view, that one looks really quite intense. You think, oh goodness me, inside this model of care, look at all these things I have to do. I really just want to show you this because if you do something as simple as doing telephone triage, you resolve all that area of urgent and care. So simply setting up triage resolves those elements inside your practice. But not only will it do that, it'll actually do some stuff in all those other domains. I'm not going to dwell too long. This stuff here you'll be able to look at in your own time. But simple bedrock platform type of changes inside your practice, such as putting in triage across a whole lot of domains, makes a huge difference to your business efficiency, your workflow, and how well your patients and yourselves feel about your day. Likewise, Portal's I'm a great fan of Portals. I've been at this Portal story for a while, and still a bit embarrassed that only 12% of adult New Zealanders can actually get access to a portal, and 1% can read their own notes after us as GPs having 7 or 8 years of being given a chance to do this. But again, they're to me pretty much a no-brainer. Information that resides in our systems is not ours to own. To a large degree, patients, in my view, are owners of their own information. If they need us to help them or someone else to help them, they participate with us. We can participate in their care. The only patients in New Zealand are those that are in an intensive care unit or under an anaesthetic. The moment you're awake, you're participating or owning. And so the fact that we are not giving patients access to their information and allowing them to participate with us, I think is pretty indefensible. And again, if you were to put in a portal, which is that little there, fully functional patient portal, voila, what it does for your business, both for your business and for your patients, is that and that. So with those two simple things I showed you, which is triage and portals, the number of benefits to your practice and your patient with two simple interventions is incredibly large. And I was told I had to actually stick to 15 minutes, so I've probably done less than 15 minutes, which is good, because I imagine the end of this is lots of questions we're going to have to answer. And I will stop sharing and pass the presentation. Lance, you're still on mute.
Aha. There we go. Thank you for that. Thanks a lot, Andrew. So yeah, I'm the head of equity for ProCare and also the National Utility Triage Service, but fortunate enough to be the equity lead on Healthcare Homes. And today I'm going to just step you through what equity means to the healthcare homes, because it's front and centre of the entire model. What I personally like is these three components of healthcare homes. The first is, how do we get a better business model for our general practices so that it could free up some more money to potentially get another 0.5 nurse or a healthcare assistant that could then focus on recalls for our high needs populations. Secondly, I like that it focuses on getting our clinical staff working to the top of their scope. And the third one is which is integral, is how do we get equity of outcomes across our general practice model, which is not always there in some of our primary care models. So what I like about this is the focus on equity. So I'll just move into our presentation and then feel free to drop some questions into the chat. So firstly, what does it mean? It's strengthening equity and co-design for Māori partnerships and outcomes. So the key component of this...
Excuse me, Lance. You might just want to move into the slideshow mode itself. Not
okay.
Slideshow.
Is that better?
No, it's stuck on slide 5. It's on your slide view, but not on the slideshow.
Cool, sorry. So yes, so the key component of the co-design from an equity point of view is Māori and Pacific people have actually been heavily involved in the co-design of the healthcare homes model. So we've created a pathway where we've got consumers on our group who look at this model of care and say, what does it look like from my point of view, rather than from a clinical or referral pathway point of view. So a key component is Māori and Pacific and our whānau have been a part of developing this model of care for us. I won't talk to the slides, but they'll all be available afterwards. But you can actually see, because of this, the new healthcare home model, we have been able to improve outcomes for our Māori and Pacific communities. Dr. Andrew talked about patient portals. You know, the ability for our whānau to be able to book their own appointments online at a time that's convenient to them, to be able to log on and check their patient notes. If they're in a hurry and they can't take time off work, the ability to have a 5 or 10 minute phone call with the GP either during normal business hours or from 5 to 6 after work hours has completely closed a number of health gaps that we do have in our current primary care system. So some of these concepts have been developed by talking to our communities and talking to our whānau. But the key to the model is it puts the whānau at the centre of our model, and it wraps the services around them rather than dictating what services are to be delivered to our communities. So when we say let's focus on equity, what does that mean? We know there's a health and disability review systems review out now. We know there's a treaty claim from Y2575 out now. And what Healthcare Homes does is it's taking those recommendations and actually starts entrenching it into our healthcare model now, rather than waiting for government agencies or government policy to change. So, for example, it encourages working closer with some of your Māori or treaty partners in your communities. It encourages opening it from just the general practice model to connecting to some community services around budgeting, potentially family violence. Food bankers are now an important component that we're seeing through COVID. And it widens the scope of work from just the general practice view to a whole of health and wellbeing view. So those recommendations that have been talked about, we've actually embedding those in the medical model now. So our communities are getting much better access to health and social services through the healthcare home model. What's some of the proposed vision? So we've made this a completely unapologetically Māori model of care. So there are existing models that have been developed by Professor Sir Mason Drury. So what we do is it's all around Māori ora, whānau ora, and waiora, which effectively means healthy individuals, healthy families, and healthy environments. So because we're making it wider than just the core general practice model, it's a holistic health and wellbeing model, which ultimately we know that in general practice, probably 20% of the good work we're doing will improve someone's health and well-being. But if we're not addressing those social determinants like housing, like poor insulation, like smoking in the house, and those other social determinants, if we're not addressing those, we're not really going to be able to improve the health outcomes of our whānau as well as we could. So by wrapping around the holistic model of care in the primary care setting, will enhance our whānau's ability to improve their health and well-being much better. Whānau ora is a concept that's been around for quite a while. It just means family well-being. And once again, I'll just touch on it quickly, but effectively it's a multidiscipline team working across primary care and social care to look after our whānau and refer between social organisations and our primary care organisations. These are some of our proposed values. I won't go through them all. They're quite renowned from a Māori point of view, but if I go to my next slide here, it actually gives a bit of a translation of what those mean. I'm just going to pick on a couple. So manaakitanga, acknowledging the mana of every party in order to create an environment of respect for different perspectives and behaviours. Dr. Andrew talked about how it's actually the patient notes. It's that, so having the ability for whānau to access their own notes, determine what that means, and have an understanding on the health and well-being of their whānau, because they have a better health literacy is quite important. Kaitiakitanga, that means, by way of example, is we meet and greet people at the front desk in a polite and courtesy and culturally appropriate way. Our workforce is culturally competent and culturally safe. We're providing health literacy in a culturally appropriate way, and we're providing the workforce with toolkits on how they can do that to improve themselves in terms of their cultural safety in a clinical environment. And what does it mean for healthcare homes? Well, so in Māori space, we have a saying called "Tu Māori, by Māori, for Māori." But if you apply those logics across our whole healthcare system, what works for Māori and our other vulnerable populations works for everybody. So some of these things we've entrenched have actually had an enhancement model for our whole populations that we're managing through primary care. And the key being building relationships is probably the strongest recommendation I've seen come through healthcare homes. From a Māori perspective, if we like you and trust you, we're going to want you to work with us in a clinical environment. So building those relationships, more so by way of example now when everything's moving to virtual consultations, how do you build that rapport to do a 15 or 20-minute consult virtually if you haven't built up that rapport or that relationship throughout your clinical and patient or whānau journey? What's next? Now, virtual consultations pre-COVID was probably less than 5% in New Zealand. It's currently sitting at over 80%. So, the helpfulness of being ready for the virtual consultation through the Healthcare Homes program has actually geared up a lot of general practices to be able to deal with this virtualization as a normalized way of delivering healthcare services. So this probably will be the norm, where it will go to some people being face to face and a lot of people being virtual. So, COVID has kind of changed the playing field. So Health 101 now becomes COVID 201, which effectively is virtual consultations are quite a key thing, and integrating in this manner and providing workforce development and cultural competencies by using technology. So that's me. I'll hand you over to Dr. Nick.
Nick, you need to unmute.
All right. Well,
There we go.
lucky all of you. How are we going with the sharing? Sorry, I can't see it now, so I just have to find it again.
We've got a different view. We need to go from the beginning with the full screen.
I'll stop sharing and I'll start again. Sorry. Okay. I'll just minimize things a little here. Okay, so hopefully you can all hear me now. And what I was just saying all to myself was it's been a pretty incredible 6 or 8 weeks for me and obviously for all of you. And I just want to acknowledge the incredible change that has had to occur. And let's face it, it has been forced on both yourselves and your patients to some extent, particularly those of you not already in a healthcare home and not using the healthcare home model of care. So I want to acknowledge those challenges for all of you. So I'm Nick Chamberlain, and I used to be a GP, and at some stage I went over to the dark side. I used to be a colleague of Andrew's in Whangarei, born and bred Northlander, and now I'm his boss, which is the only reason I did it. We're in Northland pretty lucky to have been involved with healthcare homes since the beginning of the journey, really, and I think the DHB and Primary Health Organisation was in a very early starter in that, and it all stemmed from a trip that a few of us went on to have a look at other systems, and you could just see the value of this integrated model. Our model in Northland is called the neighbourhood healthcare homes because we're trying to base it around localities or neighbourhoods as well. So this last month of massive change and disruption has forced some pretty, I think, clever approaches to implementing something that was going to be really challenging and probably pushed everyone forward by about 10 years. And, usually strategy's easy and implementation's the hard part. And I think in this case, there is a risk that we've had to do this so quickly around virtualising care and making things safe for yourselves and patients that we may have left out a few steps, and I really believe that some of the support that comes from the healthcare home model and some of the things that Andrew and Lance have talked about are really vital to ensuring that there aren't some unintended consequences along the way. So I'm going to show you a couple of pretty complicated slides, and I don't want you to memorize them. But what it does show is that outside of general practice and the primary care, there's been a huge amount of work, and I think you know that, not just within the health sector, but across a lot of other sectors as well. And so I chair a multi-agency group, which includes iwi, all the councils and all of the social sector leaders, and all of them are doing a huge amount of work. And we've managed to split it into these categories, and I just wanted to give you a little sense of some of that. So obviously health is front and centre focus, and within that we've got a number of categories of work around Māori health, communication, which has been vital, screening and testing, the whole of the health sector's welfare, hospital services, and really big change within hospitals as well, and you'll have seen that on TV and various other places, so you'll know some of the structural change and the challenges there, workforce, and then primary care. So, but outside of that, there's a whole lot of work around community order, welfare, huge amount of work going on in welfare. For Northland, we've got a drought going on at the same time, so that's been a real challenge. And then there's the whole recovery process as well. So just wanted to highlight how much else at a big system level. Let's just move into the healthcare homes system level and the virtual care. So I just drew up a bit of a framework for me to help think this through, and I'll talk it through in a little more detail, if you don't mind. So I put in a number of well-known frameworks within this, and one of them is what Andrew mentioned, which is the quadruple aim that looks at not only population health and making sure that we're eliminating inequities, but also improving quality and safety and patient experience, and making sure that there's value and sustainability considered, and then the very important issue of wellbeing, and that's particularly wellbeing of the healthcare workforce and staff. So the first two, population health and improving patient experience, talk to a lot of the clinical and things that need to be considered. The next one I want to talk to you about, which is value and sustainability, is actually what sits behind all of these changes and what enables them. Has to be a sustainable business model, otherwise it's not going to last. So I'm looking at these changes and thinking there probably is some pretty good stuff in here. It's probably gone a bit far. You were all told one Sunday night that you needed to get to 70% virtual care, and by Monday you were pretty much doing it. Some of you had to shut the doors for a little while to do that, and acknowledge that, but amazingly responsive. But that's probably not the ideal, and it's somewhere less than that, and that, as Lance mentioned, I think it's currently sitting at 80% virtual care. So it's reflecting on how you can sustain this at the right level, whatever the right level is, and then I wanted to talk a bit more about the benefits of some of the changes potentially around wellbeing and the things that had to be changed. And then I've put across the top 3 levels, and they're just pretty arbitrary. They come from an old piece of work which was around the system level measures called the Integrated Performance Incentive Framework, and there were actually 4 levels. There was entry, prerequisite, then an improvement level, then excellence, and then breakthrough, and there were incentives with each of those. So I was just suggesting potentially there could be a framework around potentially financial incentives and payment models based on where you're at, and in fact that's in place a little bit already. So I thought I'd just move to each of these areas, the population health and eliminating inequities, and it occurs to me that we don't know what we don't know right now around the virtual care that's occurring. We haven't surveyed our remote and poorer and rural communities as to what is their access, but we all know it's been quieter than it probably should have been, both in hospitals and in primary care. I know it's now ramping up. What's the unmet need? Is this new model and the virtualisation that's occurred resulting in health inequities, and are there major issues around access? Because we haven't done probably as much as we could around really, really clever communication out to our communities, getting them to understand some of the issues that they probably need to understand around a virtual model of care. And some of that's winning the mindsets, but actually it's not just about patients, it's also about all of you, providers and clinicians. And I know you've been forced into this. Maybe it's going well, maybe it's not. So I think there needs to be more work around that support. But within the population health and eliminating inequities, some of the things that I think need to be thought about are around reporting access and what's going on by ethnicity, having a clear equity policy. A lot of these things are within the healthcare home components, so I won't talk too much about that. And one of the things that I kind of showed you in that big wiring diagram just before about all the interagency work is the breadth and complexity of health and social care coordination, and some of that needs to be considered within the model of care. And then obviously the opportunities around shared care. So I'll just move to the next, which is around your patient experience, and that's mainly the sorry, Andrew, if you don't like the words, but the virtual care or alternative care, and some of that we're all aware of. So all practices are doing some sort of telephone consultations now, and I heard there's still many practices that aren't doing anything in the way of video conferencing, and we don't know what patients like, but I think there's probably been some work already, and they probably do prefer a mix of both telephone consultations but also the opportunity to be able to see someone at the end of a screen. So that's something to consider, and I think it is an important part of virtual care. It's vital that practices are able to shift to a model which allows for electronic billing. We talked about the needs for some sort of electronic health records and shared electronic summary records. I believe all of that is going to become more critical in this new virtual world. And of course, we don't even know how long this is going to go on for, but in some way or another, it's going to go on for some time. I mean, I think when we're back to level 2, there'll still be, advice to try and avoid as much travel as possible and avoid too much in the way of face-to-face contact. And so I think there will, for a long time, be drivers for a change in this model of care. So just moving through that, I guess what I'm suggesting within this continuum is that some of the healthcare home components could be in a mid place of excellence, but I think to really achieve that breakthrough or really high performance, you've got to have most of those components of care, because considering equity and some of the other areas has to be just core to what you're doing. But there's a whole lot of other components which I think enhance both the clinician's experience and also patients. So this is probably the one I wanted to talk a bit more about, and I don't have the solutions, but it occurs to me that at the moment, and I don't want to go into the last few days for all of you, which has been pretty darn disappointing, I've got to say, but issues around promises or broken promises. But what I do want to talk about is the fact that the fee-for-service model, as it currently sits, probably isn't fit for purpose in a different environment like we're in at the moment. And it also shows how vulnerable practices can be to change. Okay, this is the biggest change in healthcare in 100 years or 102 years, but even so, I think this does show some of that vulnerability around the fee-for-service model. There is the option, and a number of places around the country do fund a model of care, such as a healthcare home model of care. In Northland, we put in $2 or $3 million a year to support the healthcare home model of care, and so that's an enhanced payment to support the fact that you are probably with this model of care going to be having less bums on seats. It's to encourage that and to take more of a population health approach. But, and I've said it for years, but I think it's even more appropriate now. Probably the safest and most appropriate model of care would be a salaried practice model, and that would be, based around the senior medical officer MECA, and with that, I think you have the opportunity to really take a population health approach to care and look at your whole population, and also ensure you don't get into that fee-for-service bums on seats approach. So I'll just move through to the last. All of these frameworks have wellbeing as a critical part, and let's face it, wellbeing has driven this. It's been patient wellbeing and your own safety and wellbeing has driven these changes. And quite a lot of things have happened there, and I think you're aware of all of them. But some of the critical things is ensuring you've got adequate PPE, that you've got a model and a stream for your respiratory patients, and or they all go to a testing centre or somewhere else where you don't have to care for them, and therefore can continue to care for all the non-COVID patients, because let's face it, they are the majority of our patients, and thankfully because of the effectiveness of some of these public health measures in the lockdown. And I guess really just moving through, getting the support of something like the collaborative, I think, makes a huge difference to wellbeing as well, and having that collaborative approach, and it is very supportive, I think is critical for that, and it does encourage teamwork, and some of the other initiatives that sit in there as well, such as health improvement practitioners and health coaches with the new primary mental health funding, should help and fit very nicely into that team-based healthcare home model of care. And then at some stage, there's also the benefits of working in a network or a neighbourhood and having support from your colleagues and working together in that way. My final slide is just to say this big beast is still sitting in the background. I assure you I haven't seen it, and the Minister hasn't received it yet, and possibly will soon. So I don't know what's going to be in there, but I do think there are going to be some opportunities for primary healthcare. Clearly it was written before COVID, so that will need to be taken into account. But I think there is a big focus on primary healthcare in that review, and it's going to be interesting times. So thanks very much. I'll end there and stop sharing.
Thank you, Gunpei.
It's fantastic. So the healthcare home attributes seem to make general practice more resilient, and that's certainly something that we need during this crisis. Okay, we'll move quickly into Q&A. So there is a Q&A function on your screens there. We've got a bit of a queue of questions here already, which I'm going to open up on. And if we don't get to your question, we will follow up. So if we don't get to it today, don't worry, we'll follow up on it and make sure that we cover it off. So, question that's working from the top. I will go to the top and work my way down. How have we engaged our communities for feedback, Māori and Pacific? Lance, do you want to pick that one up?
Yeah, I can pick it up. So we've each area has their own healthcare homes lead, and as part of each area, each lead goes out to their communities to bring in and run different whānau or patient voice sort of consultation processes, and then runs the potential model past them, and then those leads then bring it back to the national working group, and we discuss those at a national group. We also have a whānau person who sits at a governance level and part of our model of care, who participates at every component of Healthcare Homes Initiative.
Yeah, and I think that's answered a few questions, because we've got a raft of questions around co-design and reaching out to Māori communities. So thank you, Lance. is the TEND app or clinics a threat to primary care? Andrew, yeah.
I don't know. It's we've seen several attempts, both I guess even nationally or worldwide, of people offering virtual consultations to patients that aren't in an enrolled population. My view is that my own practice can do everything that TEN can do, probably more efficiently in a way that's more holistic, because I've got the person's notes in front of me, I've got other modalities that TEN won't do. So I can triage for the patient, I can video consult them, I can telephone consult them, I can brief message them with management of health, they can come and see me face to face. They know me, they've known me for a long time, they know the practice staff, they know my team. I don't intend to offer any of those things. It's a boutique offering for people with cash in their pocket, and I don't personally think it gives my particular practice any threat at all. Whatever TEN can do, if they can do it well, I'll do it better. I mean, I'll just take on the processes they've got and we'll work out a way of putting them into normal day-to-day work. I think everything that looks slightly like a threat to us or disruptive innovation generally comes tomorrow's business as usual, and then tend to have to try and do something that actually is smarter than what we're all actually currently doing. So I don't think particularly. I'll be interested to see how they go, but I don't think they're going to be able to remove enough business day to day to be of any particular business concern to me.
Yeah, I agree. I think there's an opportunity there to incorporate what TEN offers into mainstream general practice in any case, and I think the healthcare home has done that. So here's a question for Nick. Will there be pressure on DHBs who are not currently funding healthcare homes to start contributing?
Yeah, so look, I've been trying to pressure for years DHBs that aren't, and there has been some change there, and we have seen some DHBs who are doing that. So Northland aren't alone. There are a number that are, but I think this new environment is a really good opportunity for healthcare home consideration of support for healthcare homes at a DHB level, certainly at a PHO level and at a practice level. But there's also some potential for national support there, and I think that needs to be considered, because there might be the healthcare home full-blown model of care, but there's also the healthcare home light, I'll call it. I don't know if it actually exists, but certainly that's an opportunity, I think, for practices who don't want to go all the way. It sounds like a lot of you are doing that to some extent, and it sounds like the collaborative is